Hello everyone. In today's video, we are going to study dyslipidemia. Dyslipidemia is divided into two parts. One is on family medicine chapter of Toronto notes, and the other one is endocrinology. So we will start from family medicine in this video, and the next video we will talk about dyslipidemia from endocrinology. So let's start from the MCC objectives. In MCC objective, you can find dyslipidemia as abnormal lipids on in the section alphabet A. So let's just quickly go through this objective, and then we will continue from Toronto notes. Okay, so here you go. Abnormal lipids, hypercholesterolemia is a common and important modifiable risk factor for ischemic heart disease, cerebrovascular disease, peripheral vascular disease. Determination of level is usually based on the concomitant risk. Causes are hypercholesterolemia, elevated low LDL, lipoprotein A. Primary causes familial combined hyperlipidemia, polygenic familial hypercholesterolemia. Then secondary causes are endocrine, diabetes, hypothyroidism, cholestatic liver disease, nephrotic syndrome like CKD. Other causes like tobacco, cigarettes, obesity, drugs, steroids, hyperglyceridemias is another type of hyperlipidemia. The primary cause is familial hypertriglyceridemia, and secondary causes of hypertriglyceridemia is obesity, diabetes, nephrotic syndrome, drugs like estrogens, alcohol. Low HDL levels are primary or could be secondary. Secondary is obesity, drugs like anabolic steroids, and metabolic syndrome. So they have divided dyslipidemias into three different classification. One is high cholesterol, second is high triglycerides, and the third is low LDL. So if the cholesterol is high, triglyceride is high, or LDL is low, this is dyslipidemia. Okay, so and they have then divided the primary and the secondary causes. For hypercholesterolemia, they have familial combined hyperlipidemia, polygenic familial hypercholesterolemia. Secondary causes are diabetes, hypothyroidism, cholestatic liver disease, nephrotic syndromes like CKD, tobacco, cigarettes, obesity, and drugs like steroids. For triglycerides, the secondary causes are similar to the primary one, to the hypercholesterolemia ones, but the drug is different here, that is estrogen, and there is an additional one, that is alcohol. And tobacco is a risk factor for hypercholesterolemia, and alcohol is a risk factor for hypertriglyceridemia. Now, moving on, low LDL, the secondary causes are anabolic steroids, metabolic syndrome, obesity. Given the patient with abnormal serum lipids, the candidate will diagnose the cause, severity, complications, and particularly the candidate will identify those patients who would benefit from serum cholesterol reduction and determine whether both primary or secondary prevention measures are needed. Features of a physical history and physical examinations aimed at identifying patients with immutable causes of lipid abnormalities, hypothyroidism, identification of the patient who are risk factor for ischemic heart disease, investigations and the causes of lipid abnormalities, management plan, recommending lifestyle modification, pharmacological therapy as appropriate, discussing risk and benefit of primary versus secondary prophylaxis for lipid lowering drugs, identify patients need specialized care. So this is the objective. So most importantly, you need to know the classifications and the patient's risk factor, and then you would also need to know the management plan. Okay, so let's get into Toronto notes. And Toronto notes, the first part of dyslipidemia is in family medicine. So let's start from there. Dyslipidemia, on this right side, there's a box which shows signs of hyperlipidemia. Xanthorrhea, plaques in the intimal layer of the arterial wall. Xanthosmata is a sharply demarcated yellowish deposition on the underneath the skin, usually around the eyelid. Tendinous xanthomas is lipid deposit in the tendon, especially in Achilles tendon. Eruptive xanthomas is hypertriglyceridemia induced reddish yellow pruritic painful papular or nodular rash. Lipidemia retinalis is characterized by creamy white colored retinal blood vessels occurs only with extreme hypertriglyceridemia. Corneal arcus is arcus senilis is a lipid deposit in the cornea. So there are different signs of hyperlipidemia which are seen by the physician. To calculate FRS, so Framingham heart study is basically a calculator that we usually use in clinical practices to assess if the patient is at high risk, low risk, or moderate risk. So let's start with this table, with this flowchart first. So risk assessment, stratification, and treatment consideration. So we use FRS or cardiovascular life expectancy model, that is CLEM. Repeat screening every 5 years if FRS is less than 5. Every year for FRS more than 5. So if the patient is at less than 5%, so this is basically a calculator. Let me show you exactly how this calculator looks like. Framingham risk score calculator. So this is practically a calculator that we are using in the clinical setup. So let's say a patient is 60-year-old and she's a female. Yes, she smokes. Her total cholesterol is, let's say, 250. Her LDL is, let's say, 50. Her systolic blood pressure is 135. Blood pressure treated with medication, yes. So her risk, FRS is score risk is 8%. Okay. So let's go to the next step. Advises. Patient with high risk score should be counseled aggressively about social factors contributing to the risk: smoking, exercise, weight. Also managed with blood pressure and lipid. So lipid reduction therapy should be advised to this patient because the risk is 8%, which is a high risk person or patient. So let's go ahead and see. Um, so then, now FRS score is if it's less than 5%, we have to repeat every 5 year. But if it's more than 5, then you have to repeat every year. What do you have to repeat? You have to repeat screening. What that screening is? It's a lipid cholesterol workup basically. So if the score is less than 10, no pharmacotherapy. If the score is 10 to 19, then that's an intermediate risk. If it's more than 20, then it's a high risk. Okay, so if it's a low score, no therapy, no pharmacotherapy. Primary prevention conditions are intermediate risk or high risk. So intermediate risk are LDL more than 3.5 or non-HDL more than 4.3, ApoB more than 1.2, or men more than 50 and women more than 60 with one additional risk factor. So if a man is more than 50 years, you have to consider that he is at risk, intermediate risk factor. And if woman is more than 60 years with one additional risk factor, what that risk factor is, she is having low HDL, impaired fasting glucose, high waist circumference, she is a smoker, hypertension, with presence of other modifiable risk factors like high sensitivity CRP more than 2, coronary artery calcium more than 0, family history of premature coronary artery disease, high lipoprotein A more than 50. So you don't have to remember everything, just make a good concept of it that if men is 50 more than 50 years of age with high LDL or low HDL, that's a risk factor. If woman is having more than 3.5 LDL, she's more than 60 years of age, she has a risk factor, let's say she's diabetic or she has hypertension or she is a smoker, she is obese, then she is at an intermediate risk. Then that is 10 to 19% of FRS. If FRS is more than 20%, then that patient is at high risk. So in this condition, you have to consult the primary prevention conditions. You have to think, advise patient about weight loss, smoking, reduction of weight, blood pressure control, all these things. Now, what are the statin indicated conditions? No matter what, you have to give statin. That is clinical atherosclerosis, abdominal aortic aneurysm, most diabetic, including more than 40 year, more than 30 and 25-year duration, type 1 diabetes, microvascular CKD. So these are the conditions where you have to give statins. Which are the conditions? Let's say patient is diabetic, he's more than 40 years of age, or he is more than 30 years, but his diabetes has been lasting for more than 25 years now. He has developed CKD or microvascular conditions. Patient has abdominal aortic aneurysm, or he has clinical atherosclerosis, right? So these are the things where you have to consider that he is requiring statin. Now, LDL is more than 5 and genetic dyslipidemia is also one of the conditions for statin indications. There are conditions which are genetics and in which there is high cholesterol in patient. Let's say if a patient is 25-year-old, LDL more than 5, he has a condition that runs in the family, that is genetic dyslipidemia, you have to give statin. Why? Because high cholesterol is a risk factor to develop cardiac conditions. So in this flow chart throughout, we have learned that we have to consider FRS score. FRS less than 5%, screen every 5 year. FRS more than 5%, screen every year. If FRS less than 10%, patient at low risk. If more than 10%, less than 20%, then intermediate risk. Intermediate risk, you have to look for LDL. LDL more than 3.5 millimoles, then look for the age. Patient is more than 50 years, male, intermediate risk. Female more than 60 with one additional risk factor, hypertension, diabetes, or waist circumference, patient is intermediate risk. So discuss primary prevention conditions. High risk patient or statin induced conditions are atherosclerosis clinically, genetic dyslipidemias, age more than 40, diabetic patients, or age more than 30 with more than 25 years of diabetes, microvascular disease, CKD. These are all conditions related to statin induced. In these conditions, you have to give statin to the patient. So FRS is very important to consider dyslipidemia. Now, discuss more behavioral modifications. What are the things that you're going to tell the patient? Number one is smoking cessation. Number two is diet. Adopt a healthy dietary pattern. Number three is exercise. How much exercise? 150 minutes walk per week of moderate to vigorous aerobic exercise. So three most important things. One is smoking cessation. Two is diet, healthy dietary pattern. Number three is exercise. How much exercise? 150 minutes per week of moderate to vigorous aerobic exercise. Now, initiate statin therapy, treat to target approach, confirm adherence and barrier to use. Then LDL should go less than 2 millimole per liter or more than 50% reduction. And then LDL, if more than 50% reduction, target achieved or maximally tolerated dose. So what you need to do is, let's say patient needs statin now and you have prescribed the patient, you have discussed the behavioral modification, along with that you have also given a prescription. After 3 months, you will reassess his lipid profile. You will look for LDL-C. If LDL-C is going beyond less than 2 millimole, that's fine. Or let's say if it was 3.5, now it is 50% reduced, that it is now 1.5. That means your goal is achieved. Now you continue on the therapy, monitor response to statin, RX, healthy behaviors, continue that. But let's say after 3 months, patient is coming back. Previously his LDL-C was 3.5, and now after 3 months it is 3. But 3 means it has not reduced to 50%, or it is not less than 2. Then what are you going to do now? So last time you prescribed him statins 10 milligram once daily. Now you will upgrade the dose to 20 milligram once daily. So you will double the dose. Okay. So target achieve on maximally tolerated dose? No. So discuss add-on therapy. Now, one thing is to increase the dose. Second thing is to add on the therapy. Okay, evaluate reduction in cardiovascular risk versus additional cost and side effects. Add-on therapy. What add-on therapy are you going to prescribe? Ezetimibe is the first line. Now, bile acid sequestrant it is. After ezetimibe, the second line is PCSK9 inhibitors. Ezetimibe or PCSK9 inhibitors. So these are the two drugs that are advised for add-on therapy. So you need to learn this, and I hope this discussion might have helped you a lot. FRS is the first thing, then dividing them into the low risk, high risk, intermediate risk, and then statin induced condition. You have to discuss the behavioral modification, smoking cessation, diet, and then exercise. And after that, you have to look for LDL-C in 3 months. Has it reduced to more than 50%, or is it less than 2? That's fine. If not, then increase the dose. If increasing dose maximally, even that's not helping, then add-on therapy. Ezetimibe is the first line, PCSK9 is the second line. That's how you do it. Now, risk factor for screening dyslipidemia on the right side. Men and women aged more than 40 or postmenopausal, increase incidence in indigenous individuals or individuals of South Asian ancestry. These are the risk factor for screening dyslipidemia. Now, cigarette smoker, type 2 diabetes, arterial hypertension, familial history of premature cardiovascular disease, men aged less than 55, women aged less than 65, in the first degree relative, family history of dyslipidemia, erectile dysfunction, CKD, inflammatory disease like lupus, RA, psoriatic arthritis, IBD, HIV infection, COPD, clinical evidence of atherosclerosis, abdominal aortic aneurysm, stigmata of dyslipidemia, arcus cornea, xanthomas, obesity of BMI more than 30, hypertensive disease of pregnancy. These are all the risk factors where you have to start screening for high lipids. Okay. Now, definition: abnormal elevation of plasma cholesterol or triglyceride level is known as dyslipidemia. Endocrinology 3, they are also indicating you to read it from there. So I will try to make a video on that. The next video will be on that. So endocrinology 3 is very essential. So not only family medicine part of dyslipidemia will cover the entire objective. You also have to cover it from endocrinology. Okay. Now, assessment: screen with full lipid profile every 1 to 3 years in males and females more than 40 who are menopausal or at any age of adult with additional dyslipidemia risk factor, and in the late postpartum period for women who have had pregnancy related complication, hypertensive disease of pregnancy, gestational diabetes, preterm labor, stillbirth, low birth weight of infant, placental abruption, history and examination, measure standard lipid profile, glucose, EGFR, screen for secondary causes like hypothyroidism, CKD, diabetes mellitus, nephrotic, and liver disease. So now they are telling you to whom you have to screen. If a patient is more than 40 years, you have to screen every 1 to 3 years in male or female. And if the female patient with any gynecological or obstetric complication, you have to screen her for lipid profile as well. And then you have to check for additional secondary risk factors like thyroid, kidney problems, diabetic problems, or liver problems. Risk category: estimate using FRS for assessing 10-year risk for developing coronary artery disease. FRS is calculated based on gender, age, LDL, triglycerides, systolic blood pressure, smoking, and diabetes. We have seen that calculator already. If you don't remember, I'll just show you once again. So this is the FRS Framingham risk score for coronary heart disease. So these are the components of FRS. Okay. So you don't have to learn each and every one, but you should know. Okay. If you practically study these things, you will remember it better. And this is actually practice in Canada. In clinics, we do practice FRS calculation. Family history of premature cardiovascular disease less than 55 in the first degree male relative or less than 65 in female doubles the FRS. So if there is a young history of premature cardiovascular disease, then it doubles the FRS. To be completed for men and women age 40 to 75 every 3 to 5 years. CV age is calculated as patient's age minus the difference between his or her estimated remaining life expectancy. So you can and the average remaining life expectancy of Canadians at the same age, and sex. Used to increase adherence to therapy and reaffirms positive effect of following therapy. Treatment decision focuses on LDL levels and FRS risk. The alternate primary targets are ApoB and non-HDLC. If moderate risk, then LDL less than 3.5, treatment decision threshold shifted to ApoB more than 1.2 or non-HDLC more than 4.3. So you need to also see you are seeing LDLC. Along with that, you are also looking at ApoB if it's more than 1.2 or non-HDLC if it's more than 4.3. Other targets include triglyceride HDL ratio, ApoB, ApoA1, high sensitivity CRP, and non-HDLC. These are the components they are looking on the cholesterol profile. Now, what is the management? Intensity and the type of treatment is guided by risk category. That's what we have learned in the above flowchart. Use decision-making aids such as West Science Medicine. Health behavior interventions can decrease LDLC by up to 10%. So these are now management part is very very important. You need to learn like which behavior is reducing to which extent. So health behavior intervention is reducing the LDLC by 10%. This was one of the questions, so you need to remember these percentages as well. So health behaviors reduces LDLC by 10%. Smoking cessation was the first thing that we discussed, likely the most important factor, important for preventing coronary artery disease. So remember, smoking is the first thing in dyslipidemia that we need to emphasize on. After smoking, we emphasize on diet, because in MCQs they might ask you, they may give you which one of the following is the most effective one for reducing LDL or the cholesterol. So first thing first, behavior modification, smoking cessation. Second is diet, and third is exercise. So the type, the order they are mentioning it in the book, remember it in the same order. So smoking is first, dietary modification is second. Reduce saturated fats, red meat, refined sugar, alcohol, consume nuts, fruits, vegetables, poultry fats, poultry, fish. Third is physical activity. At least 150 minutes of moderate to vigorous intensity aerobic exercise per week in bouts of more than 10 minutes reduce cardiovascular risk. Employ inconsistent lifestyle modification for at least 3 months before considering drug therapy. High risk patient should start treatment immediately with concurrent health behavior intervention. So if the patient is not high risk, let's say a 40-year-old coming to you for general physical examination, you have done LDL cholesterol profile as well. On LDL lipid profile, you've seen slightly raised cholesterol. You will advise him lifestyle modification first, and after 3 months you will repeat the blood work and see if it is going down. You don't need to do anything, but if it stays the same or if it's increasing, then you need to consider adding the therapy. Pharmacotherapy can reduce LDLC by 40%. So lifestyle reduces by 10% and LDLC by pharmacotherapy reduces by 40%. For a comparison of dyslipidemia medication, E6. First line monotherapy is statin, which is HMG-CoA reductase inhibitor. Risk is myopathy. Myalgia is rhabdomyolysis. If severe, side effect ezetimibe. If the patient is complaining like I have severe pain in my arms, then you can switch to ezetimibe. Cholesterol absorption inhibitor can be used for up to 19% reduction in LDLC. So statin therapy, pharmacotherapy was giving 40% reduction, ezetimibe is giving 19% reduction. Post-acute coronary syndrome, cholesterol absorption inhibitors, ezetimibe in addition to simvastatin reduces mortality, attained lipid targets of less than 1.8 and improve outcomes in high-risk individuals. Lower evidence for other agents like bile acid sequestrants, niacin fibrates, PCSK9 inhibitors. Monitor ALT, so you have to see creatine kinase, creatinine. Why? You have to look for myopathy at the baseline of 6 weeks and later for signs of transaminitis, myositis. Tolerate rise in CK for up to 10 times upper limit of normal versus 2 to 3 times symptomatic. Or if the serum creatinine rises by 25%, less than 25%. So you need to understand this. Look, you have the patient was there, you've started him on statin now, and after 6 weeks, you will see if the patient is having myositis, the symptoms of myositis, and you will monitor his creatinine kinase, and if creatinine kinase goes up more than 2 to 3 times and he is symptomatic, then you can switch to ezetimibe. But if let's say it is going up to 2 to 3 times, but the patient is not symptomatic, so you can continue the medication. Okay, so you have to monitor creatinine, you have to monitor CK, you have to monitor ALT. And if a patient is symptomatic with rising CK levels, that means patient is developing myositis, you can switch the drug to ezetimibe in that scenario. Okay, if adequate response is achieved, evaluate fasting lipid every 6 to 12 months. First you will see in 3 months, and then you will first you will see in 6 weeks the CK level. Then you will reassess lipid profile in 3 months, and then after 3 months, if it's static, then you will monitor it every 6 to 12 months. Now, if the patient has isolated hypertriglyceridemia, does not increase the cardiovascular risk. Only if triglycerides is going high, you don't have to be worried about that. Normal HDLC and total cholesterol, elevated triglyceride. Mild more than 2.2, marked risk more than 5.6. Principal therapy if lifestyle modification, weight loss, exercise, avoidance of smoking, alcohol, effective blood glucose control in those with diabetes mellitus, increase omega-3 fatty acid intake. Severe hypertriglyceridemia, that is more than 10 now, is associated with increased risk of acute pancreatitis. So drug therapy is nicotinic acid and fibrates. So not every component of lipid profile is going to denote that the patient is having dyslipidemia. No. What are the components that we were looking? Hypertriglycerides, hypercholesterol, hypertriglyceride, low HDL. But if it's isolatedly hypertriglyceride, that means HDL is okay, total cholesterol is okay, only triglyceride is high. So if it's more than 10, then patient is at risk for acute pancreatitis. And what you have to do, you have to give patient nicotinic acid and fibrates. So patient is lower risk for pancreatitis, not coronary artery disease. Okay, so these are the things that you will consider. On the right hand side, there are the boxes that we have to read. This is non-fasting. They're comparing non-fasting lipids versus fasting lipids. So if non-fasting lipids can be used for Framingham risk assessment, hold same prognostic values as fasting. If in fasted versus non-fasted sample, can vary by less than 2%. LDL varies by less than 10%, varies by less than 20%. Recently, non-fasting LDL has same prognostic values as fasting. So that's something that you can think about as, like, previously doctors were prescribing patient to do fasting lipid profile, but now the studies have shown that there's no significant effect on the prognostic value. LDL cannot be calculated when triglyceride is more than 4.5. Safety of statins. Trials have shown that statin therapy slightly increases the incidence of type 2 diabetes and hemorrhagic stroke. However, absolute risk is smaller relative to reductions in coronary events. Their clinical significance is not great enough to recommend against use of statins. So, hemorrhagic stroke and type 2 diabetes. Use with caution when prescribing combined statin with fibrate therapy, as there have been concern regarding safety of certain combination, potential increase in myalgia, CK elevation, myopathies, and rhabdomyolysis, fibrates and statins. So together, if we are using them, we need to consider that patient may develop myalgias or rhabdomyolysis. Clinical definition of metabolic syndrome: central obesity, men waist circumference of more than 95 and women more than 80 centimeter, plus any two of the following four factors. Which are the four following factors? Triglyceride level more than 1.7, HDLC in men less than 1 and in women less than 1.3, blood pressure of more than 130 by 85, or taking blood pressure medication, fasting glucose of more than 5.6. So all those similar risk factors. Metabolic syndrome, we are considering waist circumference along with two of the following. Which of the which two? It could be blood pressure, it could be glucose, it could be LDL, or it could be triglyceride. Okay. Now, statin related adverse event. Conclusion is statin therapy was associated with greater odds of adverse event compared with placebo. Similar rates of serious adverse event were observed with, between statins and placebo. So, statin adverse effect is just, you need to remember, this is myalgias and rhabdomyolysis, elevated CK levels. Patient may complain of having muscle pains, but that's not something that we would, not give patient medication. We would rather switch it to ezetimibe if it's, getting severe. So this is the family medicine part of dyslipidemia. I would just quickly show you the endocrinology part as well, just to make sure that you also cover dyslipidemia from that. So this is endocrinology. If you scroll down, you will see the first chapter in endocrinology is dyslipidemia. So this is a detailed part. In this section, the most important thing that you have to do is, number one is this primary dyslipidemia table. This is a very important table because in this table you will differentiate between familial hypercholesterolemia, familial combined hyperlipidemia, because every different condition has their own characteristic lab abnormality. So you will learn that, and then the treatment as well. And moving forward, you will look into the secondary causes of dyslipidemia and then screening. So we have mostly done the screening part, and now this is the primary prevention FRS, similar table that we've already done. There's nothing different in there in this table. It's just the colors which are different. So you've mostly covered this part as well. So I'm going to make a second video to cover the endocrinology part of dyslipidemia. So continue watching and make sure you subscribe to my channel and comment down if you have any questions. Good luck with your preparation.